We see you guys.
Good.
You wanna present your
actually have
case?
two-
What you got?
We have two live cases. This is my TMVR. Bioprosthetic mitral valve degeneration, and we want to show how we can, take care of that. So if they can show the slides of a case presentation, JG. So after this, we have another tower case also that we are ready with.
Okay.
So if you can show, live case 6. So this is a 73-year-old female who presented with worsening symptoms of shortness of breath.
Can we get Dr. Reitman up here? Hold on a moment. Let's close that front door to minimize the risk. Okay, great. Let's go.
Okay, so definitely had a lot of symptoms. And then past medical history of hypertension, diabetes, rheumatoid arthritis, and more important is morbid obesity that she has had. So I've actually been seeing this patient in my office and in the clinic for a long time, thinking that we can manage medically, but symptoms actually have been worse for the last couple of months. So past medical history, if you see here, she had MR and MVR with the 27 perimount valve in 2007 and also LAA closure. So she has been on good therapy for heart failure, as you see there.
10,000.
And TE had shown, which I think we can. Are we ready with the TE?
Malcolm, you want to show us and tell us what you find?
Yeah. So Malcolm is here. Can you hear him?
Yeah, he's showing live now.
Okay.
Speak up.
Here the left ventricular function, the LV is moderately dilated and moderately reduced in function. The estimated.
Not here.
Fix it.
Can you hear me now?
Yes. Much better.
Okay. So firstly, starting with the left ventricle, left ventricle is moderately dilated and moderately reduced in function. The estimated ejection fraction is 35%. We're looking now at the mitral bioprosthesis, the Perimount 6900. You can see that the leaflets are thickened, calcified, and also restricted in motion. There's mild transvalvular regurgitation. The mean gradient, transmitral mean gradient is 7 millimeters of mercury. The pressure half time is increased to 220 milliseconds. And when we use the continuity method, the valve area is 0.9 centimeters squared. And the DBI also elevated 2.5. So overall, the features are in keeping with structural degeneration of the mitral valve bioprosthesis. You can see here the 3D view of the mitral valve on FAST shows that two of the leaflets are very thickened and essentially immobile with only one mobile leaflet. And very minimal transvalvular regurgitation. This is a multiplanar reconstruction of the mitral valve bioprosthesis using our upgraded EPIC software version 9. And you can see again in these views as well, the very thickened and restricted mitral valve leaflets. And the aorta mitral angulation is also quite generous at 138 degrees. And this is our transseptal view showing the very large left atrium consistent with the mitral valve disease. And this is what we're using from the procedure onwards. Thank you.
Okay, so we can go back to the slides.
So
he just went through all that.
Stenosis, and she has symptomatic mitral stenosis. She's still in sinus rhythm or in atrial fibrillation?
She's in sinus rhythm, yeah.
Okay.
We can show the a little bit of hemodynamics, and you can mention, talk the CT scan,
So you can see here on the back one slide that this is a prosthetic mitral valve. You can see it's a 27 millimeter Paramount 6900 with very nice fluoroscopic signature. We'll show you in a moment. And of course, the internal diameter is 125 and area 490. So aortic mitral angle is already mentioned. And you can see LVOT, neo-LVOT is wide open. This patient has a reduced ejection fraction. So no worry about LVOT obstruction. You can see the projection here. So it will be a 26 Sapien 3 Ultra plus 2 cc. And you can see that here, what the valve looks like. We're not going to fracture on this particular patient because there's no issue with the mismatch. And certainly, I think mitral fracture is still a bit more challenging than aortic fracture. And we decided we'll go with 26 rather than 29 for two reasons. One is that it's a prosthetic stenosis, as you saw earlier, so it's very thick leaflet, so it's not going to be worried about migration. The second is we found that if you optimally expand the 26 valve, you have actually better gradients than an underexpanded 29. In fact, we had a patient that we actually put a 29 valve directly through in the operating room, end up being degenerated in 3 months, and then we had to take it out and put a 26 in there because the gradient was very high, was degenerated because of underexpansion. So you can see that how we're going to put in this valve. And I think this is the summary of the case.
What we have. So for the Transseptal, actually, we wanted to show this new device that has been out
Let's
there.
go live now, please.
Can we go live and show the ceiling camera?
Yes.
Yeah, we can see it.
Yeah. Yeah, so this is the device which is called a Safe Cross. Since when you see it, you'll know why they call it Safe Cross. So if you see here, these attachments that we have here, so it's more of like an Agilis catheter, and you can see there's once we are in the IVC, we will inflate the balloon like a swan, then we'll go up and down. Yeah. Unlike other.
Bring it down more.
Okay, yeah.
You want to show?
No.
Are you inside the body? We want to see
No. Just showing you. Yeah. So this is how it happens.
Show
Can
us
you?
it, because we're just seeing your hands, not the device.
I know. So this is where we are. So when I go, you can see here.
Yeah,
So
and there's a balloon tip there.
And then you go up with the balloon catheter. Is that what you said? Yeah.
No. What happens is there is a balloon here. As soon as we are in the IVC, when the IVC reaches the left atrium here, we will inflate the balloon, and then we will float it around and then find the right part of the septum. You can see it, right?
Interesting. Yeah. Yes, very nice.
A little different than the traditional transseptal that we do. Go all the way to SVC, then keep coming down, then go posterior and all that. So
Antonio,
you'll see how we do it with this.
This transseptal way or no?
No. I mean,
So
it's about 20 years that we are doing well with the regular one.
Okay, let's see what you do with it. And so does Dr. Kinney. She has a very good transseptal technique, but she wants to show us this one. Okay.
Yeah, this is a balloon tip transseptal system, which is RF frequency. So in challenging anatomy, let's say you have a lot of leads.
One is the challenging anatomy, but more important, I think these patients who have, if they have multiple leads, some of them actually have an atrial lead, then you will have the coronary sinus lead, LV lead. So in that kind of situation, this really helps.
Yeah, so you can see we're now approaching the IVC. Yep,
so
we
once
stop
you're
there.
in IVC, you stop here. Yeah.
Yep. So now we bring back the dilator, okay, and we're going to exchange now this wire to the Confida, right? Or Safari, where we're going to be using it to actually cross to here.
Oh, you're going to make the hole.
The dilator.
Okay.
Yeah. Okay, floral.
Good. And where is that?
In fact, you can see that we're already kind of tenting on the septum already. So let me just.
We're going to inflate the balloon.
Yeah. Okay. So 1 second. You have floor.
No. To make the hole burn.
Yeah. No, I know. Where's the pedal?
Pedal.
Oh, there. It's on this side. Can you
bring it to me?
Yeah. Here. Okay.
You want to do the pedal?
Yeah.
Okay.
Okay. So you can see now on floral. Let's stop on.
So
I'm going to inflate the balloon. Actually, we're tenting against the septum already. Let's bring it back a little bit. And you can see that we're inflating. You can see the on floral, right?
Yeah,
you can see the balloon.
Yeah.
Yeah, we see the
balloon.
We're
going to inflate
and on that. Yeah, you can also see it on the TE.
Yeah,
right.
You're going to see it just a little bit. You don't have to go too much. You can see TE.
Yeah.
You see the septal.
TE, but we see mostly.
Can you show the echo? Yeah. Perfect.
We
okay.
see the TE is smaller, but we see it that you're right there, right up against it. You're right up against the septum.
So,
we see it nicely.
Yeah, it's very posterior. So maybe just come back a little bit. Yeah. It's we're off again. Yeah, there you go. Okay, good.
I think we're good.
How posterior we are? We need to go a little more posterior, right?
Yeah, a little more posterior, yes.
Yeah, because you're too close to this.
Okay.
That's good.
Yeah, that looks very good.
Yeah.
That
slipped
looks good.
Okay,
right
bit, yeah.
Now can you yeah, good, this is good. Okay.
It's good?
Yeah.
Okay.
So now let's measure.
It slipped off. Yeah.
Okay. There.
Yeah. Okay, good. So I'm going to advance the dilator a little bit just to see. Okay, can you look at the short axis, please, Malcolm?
Yeah. So you got.
Looks very good, right?
That's very
Right.
good
You're
there.
away
Yeah.
And then
from
can you
the
measure the height,
aorta,
please?
which looks good, yeah.
Yeah. Can you
Yeah.
measure the height, please, on 4-chamber?
Yeah. I have to.
Okay, reverse 4-chamber is fine. You can see
Yeah.
that here. Remember, you have to be at least 2.5 to 3.5 distance from the mitral valve. Otherwise, you will not be able to deploy because you'll be stuck across the septum. Looks good. Very good. Nice and high. And you also, the key is that the Dr. Kinney will tell you that the transseptal position should be below the bottom half of the prosthetic valve. Otherwise, you're going to have a tough time railing. Okay?
So take a cine so we can explain a little
okay.
bit. Yeah. So you go on cine,
Okay?
you see the surgical valve, you draw a line in the center. So your transseptal should be below that line. So I think we can see the trajectory will be very good, the way it looks like.
Yeah. So, Malcolm, you're happy?
Yes, I'm happy. Yeah.
Okay,
We're
going to burn.
going to burn now. So this is how it works. Okay, so you see that. Okay, we now already crossed.
Yeah,
And you can see that the wire is going towards the pulmonary vein.
good.
Is it the pulmonary vein?
Yes.
Perfect.
Left
Okay,
upper
that's it. And then
Deflate the
now
balloon. Deflate.
we're going to deflate the balloon. This is probably takes a little bit of long time. We actually learned to increase the viscosity a little bit of this so that it actually has a little bit more weight to allow you to have a better control of the balloon. Because one of our early experiences is when you
Should we
contrast
try
is
to cross?
too dilated. Let me have to.
This is the only thing that's okay. We can give heparin.
Yeah, we already gave.
Okay.
ACT is cooking, right, Errol?
Okay,
Perfect.
good.
Okay. Wonderful. See, it does take a little bit long time to release this balloon. That's, I think, the only downside of this system. But I think they're modifying it to make it a little easier.
The other thing is to be pulled
Looks
back
like
a little
are
bit.
you're already
No?
across
Yeah,
and
no, it's
we
okay.
see
No, no.
it
It's safe. You
very
saved the one.
nicely.
Yeah, I mean, that's why it's called Septal. It's so straightforward in terms of how you need to.
The big syringe.
Almost there, almost there.
Big syringe. Yeah. Okay. Let's see.
You can see that here. Almost.
No, it could be that it's stuck. It's coming down. It's coming down.
We make it more viscous. That's why. Good.
What I'm saying, should we advance over the?
Yeah, you can advance the whole thing
Okay,
if you
hold
want.
on. This balloon is down.
We don't have
Balloon
to
is
because we
not
put a balloon in the
down yet.
septum anyway.
Yeah,
so
yeah.
We can just walk it out.
No.
Yeah, you want
Let's
to
see.
advance?
Now it's getting there.
No,
Just
this one, hold it.
Have some
Yeah.
patience. It's coming down. There go. Oh,
Yep, it's crossing. It's
No,
not.
we're
it's just
trying to cross. We're
Yep,
trying to
it's
cross,
dancing.
and
You can
this
see
will
that,
do it.
and you can actually cross with this
Yeah.
directly. See, it's
Yeah.
denting.
We
It's
did.
you're
crossed
crossed.
now.
You're crossed
Yeah,
now.
nicely crossed.
Good.
Okay, so we're
Come on.
gonna walk this whole thing out, and we're gonna balloon the septum. You got the balloon ready?
Good.
Okay, hold the sheet.
Yes, I have the sheet.
So you can see it's nicely parked in the left superior pulmonary vein. We have a good height from the valve. Go ahead. Yeah, why? Okay.
So there are patients with the comorbidities like low platelets, other kind of conditions.
Yeah, we just
Those are the cases
yeah.
where we know the transseptal has to be done in
Yeah.
the right spot
You can take a look.
safely.
And
Yeah.
we just did a hemophilia patient actually with this system because the patient obviously had a very high bleeding risk.
Hold the wire.
And you can see some smoke in the left atrium too. So
yeah,
can we
we
give
saw
one more
that
thousand
early
happen,
on.
please?
Yeah.
So we routinely dilate the septum because this is a valve. So we're gonna do a 12 by 40 here. Malcolm,
Okay.
our balloon is across.
Yes.
Okay, go up. So we're dilating the septum now. You
the
see
weight?
it? Yeah.
But yeah, we're gonna bring it back a little bit.
A little bit back. Yeah. Come
Okay,
back
good.
in towards the. You have too much in the LA. Yeah.
So because you don't want the valve, which is a valve,
in,
the
no?
sapient valve is, remember, it's a naked valve. You don't want it to be hung up at the septum.
That's good.
Okay, go up.
No, go up, go
Forward.
advance. That's
Yeah,
it.
you said
Go up.
up. No. Hello.
So Gilbert, why not a
Balloon is-
14 balloon? I've had them get stuck on 12
We could have done
balloons.
it.
I do a 14
Yeah,
every
we could have done a
single
14.
Mm,
We don't have a 14. That's the one.
Down.
But you saw the waist there, so we would usually use a.
I'll do one more, okay?
Yeah, we have used 12,
Okay, go.
12 for 23 and 26, and 14 for 29.
Okay, give the next
And
one.
actually, I would say
did
that,
a-
for intrepid TMVR, we use a 14 also to pass a 37 French sheet
Okay,
and never
down.
had an
Yeah.
issue. So we think, 12 should be okay here. as long as the septum, like this septum looks pretty compliant, but if the septum looks very thickened, especially like let's say the patient had a transseptal approach to the surgical mitral replacement, we would definitely consider more aggressive ballooning because you worry about the recoil and then the non-compliance holding up the valve when we cross. So, but that's a good point.
So the next step will go up with the Agilus along with the multi-purpose inside that. We already have we placed the E-sheath as soon as we got the access.
Yeah. Now it's important point that Dr. Kinney brought up about the Agilus with the multi, because remember the dilator of the Agilus is not an 035 compatible system. So you need to be able to have an 035, and this is the other advantage of this safe cross. It is also 035, similar to the VersaCross wire that some of you guys may be familiar with, the Bayless system as well. So you can see now the Agilus is coming
We can
to the
show
left
the
atrium.
hands, please, from the ceiling.
Malcolm, the Agilus is coming to the left atrium now.
Yep.
It's not there yet. Is it crossing? Yep.
Yes.
It's
Yep,
crossing
it's
nicely.
crossed.
You
Yep.
can see that clearly. It's in the left atrium because
Yep.
we are now past the mitral valve.
Yeah.
So
okay.
he's going
Take
to
out, right?
bring the Safari
The wire.
wire back. We're going to cross.
Do you think we will use what
Yep.
wire?
The stage shift out glide wire.
Yeah, we're going to use a glide wire, right?
Okay,
Yeah, and
very
he.
cool.
So Malcolm, we are turning to steer to cross the mitral valve now.
Mitral valve, yep.
What wire are you going to use
No, the
to
good-
cross now?
Straight wire, since it's mitral stenosis.
Yeah. And actually, Malcolm can even show you the nice 3D of
Yes.
the crossing.
Give me the wire.
Yeah. You know,
What is this?
3D is actually
Looks like
very
you're
helpful
very
on
well
your crossing.
positioned, but one never knows
Yeah.
until you
No,
start
the
to.
3D is actually very nice. So Malcolm will show you. So this is MPR, and you can show the mitral valve, please, Malcolm. Right?
Yeah,
You
the
want to
long
show the. Yep. So you can see.
okay.
You see that once you are positioned,
show the
you
mitral
are
valve, right?
able to get in.
You're already
Yeah.
across.
You wanna
Yeah, we see that.
Not the septum.
Yes, yes.
Yep. We already
And now
crossed.
you'll
Good.
go in
Exactly.
and
See.
change with the Safari?
Safari.
Right. The beauty of this Philips system, Malcolm just showed you, right? You see that he can instantly, using MPR, 4D MPR, and go from one part of the valve to anatomy to the other. See, look at this. He didn't even really need to redo the imaging, and he just showed you instantly the 4D MPR on the valve itself that's showing cross. So, Malcolm, you want to talk more about that?
Yeah, no, I think that the new Philips technology, the version 9, really shows the 2D images of the 3D data set really quite nicely.
Right.
And the resolution is so much better. So it really helps interventionalists with knowing where they are anatomically, and it really helps with guiding the procedure for sure.
And then take this out and then pigtail and then there's a part.
No. This is 300,
So,
right?
Dr.
You
Kinney,
can put
tell
go
us
with the
what you're
pigtails,
doing
long
right
pigtail.
now.
No, what I'm doing is I'm changing
the
it because we
Safari.
have to put a Safari wire there. To
Yeah.
do that, we have to put a long pigtail. So this is just a 300, regular 300 wire. We are taking out the multi-purpose that I used to cross. Now we'll put a long pigtail and then change to Safari wire.
Yeah.
We were initially thinking we can just go directly with Safari wire, but
That's what I
sometimes,
was thinking. I thought you were
since it's a
going in with the
stiffer, yeah,
Safari.
since it's a stiffer wire, we may get it can kick off.
Yeah, so that's a great point, Moxana. So we had some situation where the heart is quite dynamic. So actually, when we do the multi and exchange to the stiff wire, it kicked the
I see.
catheter out to the left atrium. So we just been used to this kind of stepwise exchange to minimize any kind of risk of cardiac perforation, or kind of. And also remember, you have to position the stiff wire in the curved portion facing down, not up. That's the key, like this. Like you see the pigtail?
Yeah.
It has to be like this to be able to get you coaxial for your implant.
Do we have
I
the
think
valve
that's
ready?
one of the most important thing, and that's why the pigtail is very helpful in this regard.
Okay.
Now we
now-
are going with the Safari, okay?
Yeah, we saw you put the pigtail in beautifully, and now Safari, and then your
Yes.
balloon.
Yeah, ACT about 320 now, 305. We
Yeah.
gave 1 more thousand
So we
heparin.
balloon the valve.
Do you
We didn't
plan to
really put
Yeah,
pre-dilate,
right.
or
It
you,
did
what do
not.
you do? How do you
Yes.
handle these? You always pre-dilate here?
Usually we dilate to
The
pre-dilate.
same balloon, the
I
travel
know,
balloon.
It seems
so
like the people here, we've got, we also have Arthur Reitman, who's wonderful and always
Uh-huh.
here. He's the Chief Inpatient Cardiovascular Services at Wellstar Health System in Marietta, Georgia. And I'm proud to say that
I
he's
don't think we need to
governor-elect
dilate.
of the
You want to
Georgia
dilate?
chapter of the ACC.
Okay, give us
and I'm
a
so happy
balloon
to
again.
see that. So,
No,
so
look,
Arthur-
I would say that the most important thing, and AK taught me this in 2001, the first BMV that I ever did with an Inouye balloon, AK and I did at 1 o'clock in the morning on a Thursday in someone that was older, and she taught me an important lesson at that time that is especially prominent as we've grown up around this therapy, and that is that the transseptal stick is the most important part of this entire procedure, being posterior and inferior. And even though Stam didn't measure the exact distance, you could see that the distance from the trajectory of the puncture down to the annulus was plenty enough distance.
yeah,
and I
actually
think
Malcolm
that,
did show it before you walked into the room. He did do that.
I mean, it's
yeah, we did the measure already. Yeah. Malcolm,
Right.
what was the septal height?
Yeah, we got 4.4.
4.4. That's
4.4.
plenty tall for
and
for
that
the
that
valve
leads
valve.
to, I mean, the success of the whole thing is really so dependent on being
Antonio,
vigilant.
any comments as they're going in? I mean, they're just going to do some pre-dilatation. You said you don't dilate. Why not?
But because usually, unless it's very tight, you go.
Yeah.
What we do, we
And this
always
seems like a very small balloon here.
yeah, we always use
No.
leave 2 wires because if you have difficulty to cross the septum, having a body wire, the second wire is outside the dilator, is
Where? Yeah.
on the skin. But this really helps because you can advance another balloon through the septum and facilitate crossing of the valve.
Okay.
Now this balloon, I know Roxana was a small balloon, but this is just to tell us how the
Because
trajectory
if you
of the
leave it
valve
inside
is
the sheet, you have
and
no
how
room.
it will
Okay, I
you know,
get it.
Place
go in.
2 wire and then
that's the reason
on
we
1
tried
wire
this.
we
So
place
the way
sheet,
everything
on
has
the
gone
other
so
is,
far, the valve trajectory will be good. So
Right,
we are going to
so
take out
everybody, for everybody, the
edgulous now.
reason why she used the small balloon, it was
Hold the wire, hold
just
the
to
wire.
see what the trajectory of the procedure will be when she's coming in with the mama balloon.
big
Correct.
valve. Yeah.
Correct.
If you had any
Yes,
problem,
Martha.
then we may have to dilate more or anything. But
Will
like
you ask-
Antonio just mentioned,
You can
since the valve was
do
not
the same.
AK,
Dr. Kinney,
knows
Arthur
we are
has a
okay.
question.
AK, could you
Okay, wire.
show us the way that the Sapien is mounted? Because it's backwards, and most people are not used to seeing.
Yeah, I think we will
the
see it.
Yeah,
valve
we'll
Come
get
down.
there.
Yeah,
Yeah,
in this direction.
absolutely.
I have one.
So obviously.
That's an important
thing
point
to make sure that
Arthur
you
mentioned.
mount it backwards.
So if you
Integrate,
can
we call
show
it
the
integrate.
floor, ceiling,
Show the valve, please, if
We
you
can
can.
see
Ceiling,
it, and
ceiling,
let's
come down.
just give us a.
can they come
yeah,
down?
Yeah,
Okay.
very
There you
good.
So
We see
normally
it.
you see the skirt should be down this way, means when you go. So here, the skirt should be facing now the ventricle here.
The other side, atria.
Atria. Yeah, skirt is facing the atria.
Integrate.
not the ventricle.
That's what we call integrate. Thankfully, you
Oh,
can
we've
see
seen
this
that
now with
mistake
Sapien 3 on
before.
fluoro.
Yes.
Yeah, but the good news is that you can actually see it on fluoro once you put the valve in. So that's kind of the last final check in case someone got distracted. You can still see it on fluoro to make sure.
Now today, in any of the tower cases where we use the Sapien, we never made the point, but I think as a first and a second operator, always important, you check and double check your
Yeah.
position of the skirt
Okay.
before you go in.
E is facing down, right?
Correct.
So that's
E is
important here because we're going the other way. So E has to face down. And we're going to go in now. And we're going to, once we go into the straight portion, you can see that here, we're going to bring back the E sheath so we can load the valve properly.
So E sheath will come out.
Yep, exactly. It's
Little
like this.
bit, yeah.
Exactly.
Good.
Okay, good.
So we're going to load the valve. Advance.
Watch the wire. Yeah.
Okay. Slow, gentle. Going down slowly. Advance. Okay.
Looks good.
Yeah.
Joe, stay close. Okay. Are you ready? Okay.
Okay, we are going.
We're gonna flex. Malcolm, we're gonna cross the valve.
Yep, watching you.
So you can see how easy it is to cross, and we're gonna try to make it flex a little bit. We're gonna mag in. We're gonna center the valve a little bit here.
That was
It's a-
beautiful, guys.
So we could flex a little bit. Okay, we're gonna.
These procedures used to
okay.
be so difficult, I remember, and now you're making it look
Yeah.
like so simple. All right,
Yeah.
well, let's see how you
What do
do
you
the
think?
positioning.
Can we flex a little bit more? No.
No, I have.
Unflex?
No.
No.
I unflexed and then flexed.
No, yeah.
I think
you're
I'd
right.
flex more.
Unflex, one flex a little bit.
Okay.
Okay. Here, there you go.
Good,
That's better.
And if you pull the pusher
key
back
is to
further,
pull-
Gilbert, it'll bend better for you.
Yeah. That's right.
Okay, good.
Yeah. Yeah. Push the wire a little bit first round.
Too deep.
Too ventricular, you mean? That's about right. We're gonna be slow. We're gonna have the slow inflation.
I want to go up a
Yeah.
little bit. Advance.
Don't go
It's
too
kind of hard to
ventricular.
see
Remember,
how
Okay.
No,
you're
I think we're good
positioning
now.
that.
180.
You're
do not go
mostly
too
using
ventricular.
echo, is
Do
that
not go
right?
too ventricular. Yeah. How does
Because
echo
it's
look?
sort of-
You're in really good position. Good ankle
It's not in
ventricular.
plane,
Okay,
so
good.
I
It's off.
want to know.
Yeah, do not go to ventricular. This is a very common mistake because it's much easier to push more ventricular than pulling back in terms of the thing. Yeah, go slow. But what
So
we've
did
seen
you
is that
do-
sometimes the balloon with a stenosis, it actually moves the balloon or the device more ventricularly than you intended to. What'd you say,
Okay.
Howie?
Okay, we are going up. Yes, 180.
Long pacing run, Malcolm.
Oh,
Push.
Okay, I'm going up.
Good, good. All the way.
Good.
Perfect.
Full. I'm like
okay,
10.
stop the pacing,
You see that?
guys.
No, keep pacing, keep pacing.
When you finish down, now.
Keep pacing, keep pacing,
Keep pacing, keep pacing.
Okay, back up, off.
Off. Okay, check the echo quickly.
After what I
No,
said.
so this is the key. We've seen cases actually that the valve move ventricularly because the stenotic valve actually push the valve more ventricular. And that you cannot pull back because you can actually push in more to stand the valve up, but you can't do it the other way around. When you pull back, you actually make it worse by less coaxial. So
We have the valve's in a great position. It's well seated. There's no paravalvular leak. Just some very
There's a
trivial
little bit of
transvalvular
paravalvular
regurgitation.
leak, though. I see it right there in that corner.
AK, could you describe
it's
how
the
you
wire.
position
This is the wire.
according
You think
to
it's
the
the wire?
post?
Just the wire. This
Okay,
is
let's
wire
go
related
back here.
regurgitation.
So, no, do you want us to post dilate it?
No.
No? Oh, you know what?
mean,
I
it
did
looks
not
like
see
you're
Nate.
well opposed. I don't know where, you can see.
we can post. We can
No,
post.
Malcolm, post.
I'm just checking the gradient.
It's going. Arthur, your question was how to position, right?
No, just positioning the lower end of the cage, positioning it with the 3 posts
Mean
on the
gradients.
bioprosthesis.
Okay.
Yeah.
Yeah, no, I like to do out, it depends on the height of your valve. So this is not a 29, it's a 26, so the height of the valve is shorter, right? So you can't be too ventricular because you foreshorten to a shorter height. So we start, like you said here, that you show here, the prime positioning, just at the commissural post, and you actually, from the valve in valve app, can tell you what the commissural height is of the surgical valve. So that's kind of what we do when we adjust accordingly. Valve in valve rarely embolizes unless you are too ventricular or too atrial. And I think you rather want to be a little bit more on the ventricular side so it flares out than being too atrial. How does the gradient look, Malcolm?
Yeah, so I'm getting a mean gradient of 2.
Okay.
And there's no LVOT flow acceleration. There's just wire-related regurgitation across the valve, no paravalvular regurgitation.
No PVL, right?
Okay.
No.
Okay,
Alright.
and you can show some 3D as well. Okay, so I think we're done.
I think
So
we're done. We are coming
let's leave
out.
the wire and then we have
Yeah.
the exchange with the pigtail. So
Yeah,
we always don't just pull the wire because
Check
remember,
the
this is
reflective side.
the leaflets are against you. So you don't want to tear the leaflet. Leave the wire. And then we're going to get a pigtail, exchange length, and then we're going to walk this out just like what we do to start with.
And once you take out the pigtail,
Beautiful
you always
placement,
check
guys.
for your
I mean, it looks
AST. Yeah.
beautiful. Well done.
Now you notice that it doesn't flare a little bit much ventricularly, but I think I can tell you this is a stenotic valve. The valve is not going to go anywhere. What you worry about is if the valve is regurgitant, and you don't oversize enough, and that's when and you can see the gradient is 2. So I think that makes a difference versus had you done a 29, I think your valve would have been a little bit higher gradient, not because it's a larger valve, but because you have now pinwheeling and the valve is under expanded.
Oh, we'll, okay.
Yeah, good. You want to do a
What?
Any
Gradient?
questions?
yeah.
Yeah, so if,
Gradient from what to what?
We have
do
a
a pullback,
question
you do-
here, guys.
No, we can do this way.
Go ahead.
Pull back.
if
We're gonna
the
do a
patient
pullback.
has
No, no.
atrial fibrillation,
Aorta.
of course, everybody's going to anticoagulate this patient. But if not, we still do full anticoagulation when you do mitral valve in valve. What is the regimen here?
Can you go 200 scale?
What's your regimen
200?
here, Dr. Kinney?
Yeah, no, that's a great point. We typically would
You
like
do
to put them on 3
anticoagulation for
months
how
of
long? For
warfarin
life? No,
if
6
they can
months.
tolerate it, or at least DOAC. So if they're
So
on
you put
this
them on
patient, if
NOAC
they
for
are
how
on
long? 3 months. 3 months, Dr. Kinney.
3
Oh,
months.
Dr. Sharma's
Yeah, just
here.
like the prosthetic mitral.
Needs to
Come
be
on
in
up
LA.
here. Dr. Sharma, come here.
Good, nothing.
Yeah, we're gonna pull back.
Yes.
We're gonna pull back now.
Okay, we'll see a pullback gradient.
No, no.
Okay, no gradient.
Okay.
All right,
so
good.
we'll just
This
close
is the
here.
left atrial pressure.
ESV.
Okay, and we're gonna use a J.
Can you show us the ASD? Anything to be done?
Yeah, we're gonna pull the pigtail catheter
Dr.
back
Sharma
out.
has arrived and he's amazed that you're already done.
Good. We are
Yeah.
going to
Very
the
well.
next room, room 1, for the last live case of the day.
Good.
Okay, but we need a little time, so what we might do, are
No,
you
but-
ready for the next live case?
Yeah. So, but do you want to show anything else in this case?
No, we're
Echo is
done
good,
here.
Right?
Echo is good, everything looks good.
Okay. So I think we have little discussion maybe with our faculty, the experience of the TMVR in the MAC cases. I know their overall data are not great, but maybe personal experience. I mean, we have done handful with the very well selected, with clearly circular ring cases and so on.
The fastest growing arm of the Apollo trial right now is TMVR and MAC. We're seeing most of those cases. The results actually have been very good. As you know, you guys are big enrollers in that. 80% of the ASDs are not closed nowadays, whether MAC or not MAC. We have not only done a couple of transseptal sapiens in native MAC, and I do a fair amount of open sapien in MAC. And that we basically read out what we can, take out the anterior leaflet, and then take a CUSA device and just basically smooth the calcium out, and the valve sits in it very nicely, and it works pretty well.